Good day and welcome to another webinar from the Global Summit Institute. Today we're going to have two speakers. I'm going to be the host for Dr. Sergio Escobar, and also I'll be speaking on part one for this webinar. So first I would like to introduce you to Dr. Sergio Escobar. Can you see my screen?
Yes.
Okay. Dr. Sergio Escobar is a dermatologist. He obtained his doctorate degree in dermatology from Buenos Aires, Argentina in 1986. He's an international member of the American Academy of Dermatology and has been a key opinion leader for over 30 years. He's on the scientific committee of the International Master Course on Aging Skin, INCAS, based in Paris since 2006. That's a leader academy and congress in the world for dermatology and anti-aging. Dr. Sergio was a professor in dermatology and pharmacology at Buenos Aires University and a consultant for the Favaloro Foundation in Argentina. He is the founder and director of the BAS Institute, which offers online and face-to-face teaching to medical aesthetic professionals with more than 2,500 courses sold. In addition, Dr. Sergio is the creator and coordinator of the BAS International Congress, the most important Spanish-speaking congress in the world, held in Madrid, Miami, Barcelona, Santiago de Chile, and Buenos Aires. Dr. Sergio is a key opinion leader and speaker for Galderma, Vichy, MERS, Allergan, and Epstein Barr, and has given more than 150 conferences around the world in the last 10 years.
Okay, thank you. Thank you, Sonia, for the introduction. Now I will introduce you. Dr. Sonia Bordin-Aykroyd is a dentist, researcher, and international speaker, having presented in many countries, including USA, UK, United Emirates, and Brazil. She graduated in dentistry by the University of Mogi das Cruzes, Sao Paulo, Brazil, in 1985. Has a master's degree from Eastman Dental Institute, and she's enrolled in a PhD program in lasers in biomedicine in the UK. Dr. Sonia has 36 years international work experience in Brazil, UK, and USA. She has worked in several major London hospitals in dental and buccomaxillofacial departments, and worked with buccomaxillofacial prosthetic reconstruction at the University of São Paulo, Brazil. She is certified in many orofacial aesthetic procedures, both in Brazil and USA, including lasers, visagismo, Philip Hallowell, and injectables. Dr. Sonia is on the ADA Committee Working Group for the development of ANSI ADA standards for dental lasers and the EADR Task Force Committee. She is the president elected of the Pharmacology, Toxicology, and Therapeutic Group of the EADR. She was awarded by her peers at the top 100 world doctors in dentistry, and she has several publications. Dr. Sonia is a visiting researcher at the University of São Paulo, and she was visiting laser researcher at the University Camilo Castelo Branco, Brazil, and University of Nevada in USA. She is a fellow of the International Academy of Dental Facial Aesthetics and the founder of two international training academies, the American Academy of Orofacial Harmony and the International Academy of Lasers, which offer online and face-to-face teaching to healthcare professionals in lasers, dentistry, and aesthetics. So, Sonia, let's move to your presentation. Consider aesthetic diagnosis and beauty considerations. We want to hear you.
Thank you very much. I'll be concentrating on part 1 of the facial aesthetics topics today, and I'll be talking on consideration, the aesthetic diagnosis and considerations before planning our orofacial harmonization procedures. I'll be covering aesthetic diagnosis and considerations, the aging process, orofacial harmonization, facial and facial recomposition, beauty concepts, the golden ratio, racial symmetries and proportions, and the role of the orofacial harmonization doctor. During our aesthetic diagnosis, it's important to always ask yourself, why is that patient seeking improvement of their facial features? You must include a wellness assessment with a brief evaluation, which would be within your professional scope. It's important to look for signs of physical health, like how is this patient overall health? Does this patient smoke? Has too much sun exposure? So your treatment plan cannot just be to inject or to provide the aesthetic treatment, but also to advise your patient. You also, during your physical, you might want to check, is this patient showing earlier signs of aging more than their peers? If they present with facial asymmetries or differences from the norm, they could be having an underlying medical condition. So, for instance, it's known that underdeveloped jaws can be a cause of obstructive airway, and this can show as early sign of age because it's like a loss of supporting tissue. 1 out of 15 adults have obstructive sleep apnea, and only 80% of them have and 80% of them have no idea that they do. So if you don't do airway, we wanted to think about referring this patient for investigation. And during your facial analysis profile evaluation, you'll be able to have some hints of retrogradism that could be pointing towards an obstructive or narrow airway. Now, during the facial analysis, the frontal profile, you observe that the more centralized and perpendicular the lines are, the more it evokes the sensation of harmony in that patient. So how does the age process work? The aging is a result of alterations of different structures. We lose structural tissues like bones and fat pockets that give support to the skin, but we also have tissue alterations in the soft tissue. So our muscle become more hypertrophic, and the skin reduce the ability to produce collagen and elastin. That in turns is going to alter the elasticity, texture, and color of the skin, and result also in geometric changes of the face. The other thing you want to look for while you're doing your diagnosis is check for factors that could be accelerating facial aging features of that patient. Does this patient have a hormone imbalance? Does he have high free radicals? Does he have too much free radicals that could be increasing the oxidative stress level? This can be produced by excess ultraviolet exposure, air pollution, hyperglycemia, excess sugar intake. You might want to look into their diet. But also for a lot of us here, listeners today who are dentists want to be looking at underdeveloped jaw or tooth loss or loss of vertical dimension that could be accounting for that feature of earlier aging. And we know that repetitive facial expression also is something that we can be working on with these patients. Now, an important factor that many people don't think about it, and I always like to point out, is that you must think about the mental health evaluation. You have to try and investigate if this patient is feeling their normal, because there are many conditions that influence their mental state that may have to be addressed first. So a patient who is suffering from depression, they will have a lack of confidence. They might have signs of facial dysmorphia or eating disorder, like bulimia and anorexia. If you spot any of these, you must refer this patient or think about the team approach. Do not overtreat these patients, because there will be a patient that will come back to you over and over again and say, this is still small, this lip is still small, this nose is still too big. And it's not going to be a satisfied patient, but also you're not helping that patient. Body dysmorphic disorder, for instance, is an excessive or disproportionate worry for a minimal or imaginary defect in the physical appearance of the patient. So if you can observe these things, you'll be better able to think about when you should refer or work in a team approach, but do not overtreat. Now, another part that I like to think about when programming the aesthetic diagnosis is the personal image evaluation. It's possible to make an analysis of the face based on the theory of visagismo Philip Hallowell that works on the concept that facial form, which is the shapes and line, have expression, as they can evoke feelings or emotions through visual perception or visual image. So you might want to ask yourself, what is the visual language that this patient is expressing? The visual image evaluation in this case is going to aim to establish a relationship between the facial pattern, or those shapes and lines and form, and the personality traits of these patients based on their personality traits, based on their mental temperaments. So you want to check, is this patient current facial lines and forms represent their true personal archetype, temperament, and desires? And if you're going to change the patient's facial shape, you have to be very aware of this, because it's not one size fits all. Only then you can now formulate your treatment plan for your facial recomposition. And the objective is to work on the recomposition of the face to rejuvenate or to enhance facial features, reestablishing lost facial shape, contour, volume, and skin texture and color, but based on the patient's own facial characteristics, without changing their individual self-identity. This is very important. There are a combination of techniques to reestablish their lost structure, like the dentists can work a lot with this, and also facial rejuvenation techniques to improve texture and colors, and even the lost structure, like the fat pockets, etc. But what is beauty? Humans are visual. We essentially recognize each other by sight and how humans will look. This is done by a genetically coded visual image of an ideal human face. When a face is perceived to be human, that perception sets off on us a conscious response of attraction and positive emotion. A combination of a characteristics in a face can evoke in the perceiver strong feelings of emotion, which can be either positive or negative. Now, the first association of the word beautiful is with the face, and it is defined as a quality or combination of quality or characteristics in a face, like those we'll be talking about in a minute, that can evoke in the perceiver a combination of strong positive emotion and a high degree of attraction. So you want the correct characteristics for that patient to be able to evoke in the perceiver a positive feeling of emotion, not a negative one. This combination of quality of characteristics are based on 4 aspects: color, texture, size, and shape. form. On the form, we're talking about shapes and lines. The more of these qualities evoke a positive emotion of beauty response, the more beautiful an object will look. Studies show that most people from most culture prefer the color brown at various shades. The texture is smooth, and the size of the face to be on a height of 1/7 to 1/8 of the height of the body. And cosmeceutical industry explore color, texture to make skin more attractive with their products. Accessories such as hats, hairstyles, glasses also help to give the illusion of a more pleasing facial size or form. There are many approaches to improve visual image or enhance beauty. So when you're playing with the color, you can use makeup, lasers, and energy devices. When you're improving texture, you can use, again, makeup, laser, energy devices, injectables. The size of the face, normally, let's say we're talking about a micrognatic jaw that you can improve with surgery, or you can work around injectables and fillers. And the form and shapes and lines can be improved by accessory, glasses, beard, mustache, hairstyle, surgery, and injectables again. But is beauty the same in every culture? These are the average faces from different countries. How do you define beauty in your culture? The ideal form or shape or the quality which has the most profound effect on face's overall attractiveness has never been clearly defined or understood. It varies from culture to culture. The search for the perfect beauty has been a search for the perfect form of facial beauty. When beauty is viewed as a continuous spectrum rather than just a beautiful or ugly, the spectrum of the beauty respects changes, aging process, and temperament, and in doing so, better respects individual personalities and represents reality. The golden ratio or divine proportion are pleasing proportions found in nature. It's present in the human body. It has been used by Leonardo da Vinci and many artists in art, architecture. Its concept has also been used in facial aesthetics and cosmetic dentistry. Clinically significant facial asymmetry with associated morphological, aesthetic, and stomatogenetic problems deserves investigating the underlying etiology, and this cannot be overemphasized. Everybody has asymmetries to some degrees. Everybody has some kind of a shorter height or larger one size than the other. But although fully correcting asymmetries may not be the focus of the aesthetic treatment, by improving it, we enhance the perception of youthfulness and attractiveness in the face. We now understand how to use neurotoxins to relax certain muscles and injectable to improve asymmetries. For example, when an eyebrow is lower than the other, one cheek is fuller than the others, this more is crooked to one side. We can help to make faces to appear less sad, less tired, less hungry, less saggy. This symmetry recomposition, though, require artistry skills with trained eyes, skilled hands, and a sound knowledge of anatomy. The aim of the professional, be it a plastic surgeon, a dermatologist, a dentist, an image consultant, a hairstyler, eyebrow designer, or makeup artists, is to recompose a customized personal image that truly represents who your customer is. And it requires mastering visual language. The aesthetic market demand is growing at a fast pace due to longer life expectancy, improved the health of baby boomers, social media, and higher purchasing power of our clients. So many professionals are exploiting this market slice, offering one-size-fits-all solutions to a population who is increasingly adopting robot-like models of beauty that's not necessarily right for them. People are confused with the demand provoked by social media expectations. Many of them desperately trying to fit the model of beauty portrayed by social media and marketing. But the role of the oral facial harmonization doctor is to analyze the patient's concern and to use the best approach to manage their case after excluding any medical issues, and to propose a treatment plan that's going to improve upon their facial features through the recomposition of the facial characteristics, shape, line, texture, and color that best represents what temperament the patient wants to express, and without changing their true persona. Understanding the etiology of facial asymmetry is critical with regarding to treatment planning, management, and long-term stability of your treatment. A better understanding of patients' perspectives and motivations and a sound knowledge of facial anatomy can help optimize doctor-patient's relation under the delivery of care. And with that, I would like to thank you and introduce you to part 2 of this webinar with Dr. Sergio Escobar, who will talk about injectables.
Thank you, Sonia, a lot. Let me share the screen, and we will do a brief introduction, and then we will show 2 practical videos on 2 different areas of the face to treat, the lips and the tear through area. Let's go first to the introduction. Let me share my screen and follow us at BAS.org. And let's see to go to what means fillers in facial moving and non-moving areas. Basically, if you think about the face, I suggest, and Sonia did a lot about this previously, to consider 4 axes. The first axis is skin quality. The second one is the skin tone, the saging. You can find in skin quality if the skin looks more oily, more dry, has telangiectasias, has lentigos, etc. If you go to the saging, the second point, you should consider the face contour, you should consider the corner of the mouth, you should consider the tail of the eyebrow, for example. The number 3X is the wrinkles and folds. Wrinkles that are dynamic at the beginning and then fracture the skin and turns into static. So static and dynamic wrinkles, and volume, that is the loss that we are having with the time, especially related to the deep fat compartments. So let's review what happens when we are aging. But don't forget that meanwhile this face ages, it moves. So let's make a big difference between the static approach that I will give you and then something about the dynamic approach that has a low relationship with the lips, for example. So if you consider the face, it has 5 layers. Layer 1, epidermis and dermis. Layer 2, superficial fat. Layer 3, the muscles together with the mass. Layer 4, the deep fat compartments. And layer 5, the bone and periosteum. You know, all the layers have the aging process together. Since Roerich, we know that the fat has a different way of evolution compared the superficial fat, which is divided in several compartments, and the deep fat. The deep fat is quite relevant because, as a friend of mine says, what happened is what follows. It's a very practical comparison. This is the skin. This is the superficial fat. This is the mass and the muscles. And this is the deep fat, and this is the periosteum. So the superficial fat goes down in 2 axes, the vertical and the oblique. The muscle follows the superficial fat. Meanwhile, the deep fat, what happens is that deflates with the time and lost volume in a way. So, and this evolution is upon the time different for every area. For example, the first thing that you will find in a patient is losing the volume in the deep fat compartment of the SUF, subocular oculi fat, medial and lateral. Also the upper, but the upper is masked by the skin. At the same time, or a little bit later, comes the deflation of the deep medial fat pad. So this fat pad fades down, goes down, retracts, and then you have a hole there. You have the hole of the SUF and the hole of the deep medial fat pad. The third point is the lateral, the frontal area and the lateral area, which fades. And after that comes the compartment 4 and 5, which falls in this direction, making the jowl here, and falls in this direction, making the last nasolabial fall and the marionette fall. What are the falls? The falls are superficial fat that stops from sliding because of the ligaments that are quite relevant and that you have to know very well before you go into injectables in the face. So the ligaments are fibrous tissue that burns in the periosteum and goes up to the dermis, up to the reticular dermis. So they are imprint in the surface. So if we go here, you have a very nice dissection of Dr. Sebastian Cotofana, probably one of the most relevant anatomists in the world nowadays, with the orbitary ligament, with the zygomatic ligament, with the deep fat here, the SUF lateral, with the deep fat here, the deep medial fat pad. With the time, the ligaments suffer a process of elastosis and lose, in a way, their strength. So they go down, and when they go down, the fat in the surface goes down, the skin goes down, the muscle goes down. This is what happens with the time, and one of the strategies that we that inject usually do is to put the hyaluronic acid just under the main ligament to try to revert the elastosis and the fall of the ligament, getting direct and indirect effect that I will explain. This is also a way to see that the face is divided into the ligament part and the more moving part. Take a look at this. If you consider a face from the arrow to the right, you will see in this area, this is the non-expressive area, no movement. They're just losing volume and having elastosis of the ligament. Meanwhile, this part is the moving area. So differences are very, very relevant because in the non-expressive phase, you usually employ HA, hyaluronic acid, for lifting, sometimes to restore volume. You may use even biostimulators like polylactic acid, like hydroxyapatite. Meanwhile, in the expressive phase, usually you should use hyaluronic acid on the ligaments to improve them, and the folds to reduce the aspect of the surface, sometimes to increase volume. It's not so usual, but in the tear throw I will show you today, and usually also to reduce muscle strength. So let me tell you, how does the movement affect the hyaluronic acid? Well, on one hand, it reduced the lasting effect, the duration of the hyaluronic acid. On the other hand, if the movement is so strong, it can push the filler and move the filler away from the place you have put it. Here you have an example. If you go to the nasolabial fold, to the just inferior part, and you put a lot close to the modiolus, you will find that the movement will make like a sliding of the hyaluronic acid to that side. And so the movement may displace the hyaluronic acid, and the movement may fade the hyaluronic acid earlier. Many patients ask, how does it long, doctor, the hyaluronic acid? And my answer is, it depends. If you put hyaluronic acid in the mouth, usually you won't have more than 6 months, maybe 8 months. You have to choose very well the HA. If you put it in the tear-through area, you will have more than a year, even more. Some papers recently published say even 2 years later, you can find hyaluronic acid in the tear-through area. And how hyaluronic may affect the movement? On one hand, it may cause some anestheticity if you are choosing the wrong hyaluronic, and on the other side, it can make myomodulation. Let me show you this mouth. You see this mouth and say, okay, it's not quite good because the upper lip is a little bit bigger than the lower, but take a look when she moves. What happens when she moves? What happened there? What happened there is that the hyaluronic acid that has been chosen was wrong, was too hard, was with a G prime too high. So that's the reason why you should be very careful to choose. Meanwhile, take a look at this picture of the great Mauricio de Mayo, how he turns a moving Pogonian area into a non-moving one. So some works about the rheological properties of the hyaluronic acid, and then we move to the practice. All the hyaluronic acid comes from bacterial fermentation. It depends how many milligrams they have, from 10, the lighters, to 24, usually an average between 22 and maybe 20, like this. This is usually the HA that we use for filler, because now they are coming another type that will be the object of another conference that are for different issues. Another thing, the hyaluronic acid is like a sponge. It attracts water, and depends which hyaluronic you will choose, the magnitude of water it will attract. If you use one Juvederm Ultra Plus, for example, for the tear-through, you will have a strong attracting water and a lot of swelling in the area. That's why you have to choose very well the HA you're going to use for every area in the face. Many of them are cross-linking. The cross-linker is a way to make them resist the hyaluronidase degradation. Some words that come now with the rheology are the malleability, so the ability to change the shape, the elasticity, which is the most relevant. It describes the G prime. High G prime means high elasticity, means you move it, it turns back. You move it, it turns back. So it stays there. The cohesivity, meanwhile, low G prime, you move it, it moves and keeps, and you can split your hyaluronic. The cohesivity is the ability to keep it together where you put it, and the firmness is how hard it looks when you put it in certain parts of the skin. So the G prime is quite relevant, and you can say the G prime low for moving areas. I will choose today 2 low G prime for this indication. One for a moving area, the lips, another one for a non-so-moving area, the tear-throw. Meanwhile, the high G prime are used to lift, using it in peripheral areas to improve indirectly what you want to get in the moving, in the expressing phase. So both of them has to be cross-linked. The cross-linked is something that makes it more resistant. And I have divided the face into more less mobile areas, the green one, when you do rhino modulation, face contour, tear through, the intermediate areas, the glabella, the nasolabial fold, the chin, the crow's feet, and very mobile areas. The lower part of the nasolabial fold, the upper part of the lips themselves, the frontal area. So be very careful. Just taking a home message is very low G prime in moving areas. You can go with higher G prime, stronger hyaluronics, more firm hyaluronic acid in non-moving areas. After that, here is our Instagram. Here is of the Buzz Institute. I will show you two videos. One about the lips. The second one, that is not just an injecting video, is a video which we have in the Buzz Institute to challenge what you will know or what you manage about the tear throw. But let's begin with the practice with the lips. So our first video will be on lips. Here we are.
Let's talk about the lips and their surrounding areas. First, we have to consider the layers of the face. Layer 5 is the bone layer. There you will have main arteries, especially in the upper third, some arteries relevant that go in the lower and in the middle. Fourth layer, the deep fat. This is quite relevant in mid-face, not so relevant for lips, not so relevant in lower third. The layer 3 is the muscular, the SMAS layer. There you will find many of the muscles that are quite relevant, of quite relevance in the area of the lips. And there you will see at the same time the layer 2, the superficial fat pads. Taking into account the superficial fat pads, you should consider that they descend related to two vectors, one that goes in the vertical position and the other one that goes in the obliqual position. This will lead to all the main folds that you can see in the lips and surrounding area. Let's move now to another anatomical issue. In this video, you can see the main arteries related to the lower third. There you will see the irrigation of the lips, the superior labial artery and the inferior labial artery, both of them coming from the facial artery. This is quite relevant to know that the most dangerous area are the wet limit of the lips. So usually the arteries run in the wet limit of the lip. So you have to take into account this whenever you do a filler with hyaluronic acid in the lips. We know that there are other variants that could be taken into account. These other areas are, for example, the vermilion border in close to 5% of the cases, and that the labial arteries may run even inside the muscle in close to 10%, a little bit more of the cases. More than 80% of the ways of the roots of the labial arteries are in the wet limit of the lip. So this is the area to be careful. This is the place where you have to be very careful when you are injecting the lips, because you can hit the vessel if you go to that area. Another thing that is quite relevant to know is that the arteries may be two, as you see in this video, the superior and the inferior, but some cases are where only one appears from one side and not from the other side. Maybe you can only have the superior one on one side and the inferior in both. And so there are many variations. And then the two last points that I want to focus is that the facial artery goes very close to the modiolus. So be careful when you are feeling the border of the lip. You should be very careful in that area because you can hit the artery if you go to that side, if you pass very close or pass through the modiolus. And the other thing quite relevant is that the mentonian artery, which you can see down there, is linked with the facial artery, and the mentonian artery comes from the internal carotid system. So this part of the face, the same happens in the middle face, has an anastomosis, has a joint between the superficial external carotid system, which comes with the facial artery, with the internal carotid system, which in this case comes from the mentonian artery that emerges there. Let's go forward to the next video and look for it with more detail. In my right hand, I have layer 1 and layer 2, superficial fat, dermis and epidermis. Down there, I have the layer 3 with the main vessels that you can see, and some part of the layer 4 that also you can see here in the middle face. Let's see in detail the lower third. Here you can see the posterior area of the lower third, the masseter with its limit, and the facial artery as has been drawn here, climbing up the maxillar and going into the buccal muscles to go to the surface in the middle part. Here you can see the DIO, which marks the limit between the buccal area, the middle part, and the chin area of the lower third. And here you can see the mentonian artery going into the muscle of the mentalis, and you can identify here the vessels. Here you can see some area of the platysma climbing up the lower maxilla bone. Let's work with our first patient. Here comes Andrea. She's a 25 years old lady who wanna improve her lips. I want you to stop the image here and to think what is in the mind of this girl who comes for beautification of the lips. What does she want? What does she really need to improve the beauty of these lips? And on the other hand, that's why I show you this representation of the muscle and the arteries, which is our view. Our view joins on one hand the beauty concepts and on the other hand the anatomical concepts to have, and of course also the rheological concepts of the filler. We have to choose one or two, depends on, and different fillers related to the G prime, cohesivity, and many other properties that will make us the right choice for the right person to the right result. So when we have this face, when we have this picture, we can see that this girl, even when she has her mouth relaxed, it is a little bit open. The mouth in relaxed situation usually should show the two central incisive dental pieces up to 2 to 3 millimeters. This is normal, this is quite nice. Also, it is quite nice in the frontal view, the observation of the lip vermilion border, which is very well conserved. She's very young. and also the intercolumellar area, which are really very well without any trouble. The inferior one seems to be a little hyperexposed. And if you think about the frontal view, it's quite relevant also to take a look about the muscles that surrounded the area, and on the other hand, also the lateral view. So if you look at this girl, think about the muscles, and besides that, think about watching it in a lateral view, because when you ask the patient to move the face, you will find this. And if you have this, you can watch very, very soon that the upper dental arcade is a little bit projected. Meanwhile, the lower one is a little bit in a retro position. So for the experts in the deep planes of the lower third in the dentistry, you can see that probably this girl has a type 2 way of position of the dental pieces. And this will lead to some incompetence with the mouth and will make one of the most relevant things, that is the mentalis muscle is really contracted to help the lower lip to go up. This will improve if you inject it with botulinum toxin. This is what we will do, you will see, but also it will improve a lot if you treat it with myomodulation with hyaluronic acid, because with that you will get two objectives. On one hand, you will reduce the movement. On the second hand, you will project the pogonial area, which really is something that the patient needs. So let's go on with her. After putting a cream with anesthetic power, usually compounded by lidocaine 7%, tetracaine 7%, we have also tried formulations of lidocaine 20% without any big difference. The main point with a topical anesthesia is to let the cream act in the area for at least 30 or 40 minutes. This will make really a reduction in the pain of the patient at the moment of the procedure. We clean the anesthesia, and now we are ready to work. As we have decided to do the profilometry, what we will do is to choose a low G' hyaluronic acid. Let's choose, for example, one of the Juvederm lines, very low G', the Volbella. Here we go trying to reach exactly the point where the vermilion joins with the skin. There, you will have a place immediately after, immediately down the vermilion border, you will have a place where you can put your needle without any problem, and you will have a very nice and very subtle result. So my advice in this case, in this area, is to go slowly and to treat, especially to go into in this part of the lips. Let's watch what happened in the procedure. Here we enter the whole length of the needle, pushing up a little bit the needle to see that you are in the right place. And there you begin to inject very slowly in a kind of retro injection. Remember that every time you are in a retro injection, the possibilities of hitting an artery, as I told previously, this is not the main vascular area of the lip, but is something that, let's say, can be very interesting and less dangerous that you are there. Remember that this is the layer 2. We are down the dermis, up the muscle in the layer 2, putting a very slow quantity of material. The second point is in the middle of the lip, and you go up to the tubercular. Here you can see that you go to the tuberculus of the philtrum in the layer 2. Remember that the arteries go in the wet area, and there is the place where you will deposit your volume of the hyaluronic acid, which is, as I have been told previously, very light, very low G prime. Here you put the main point and you go slowly with the needle in retro-injection to get the effect. There you see, be careful, you go through the dermis to the layer 2, the superficial fat. This is not a muscular injection. Although sometimes you can inject muscle, you here are in layer 2. There you make the movement to get the effect, and you will see how nice it looks immediately after the injection, where you have the tuberculus of the philtrum very marked, where you have the border, the vermilion border, quite well marked also. You may have some bleeding, but it's not relevant. The same in the second side. You go there, very close. You enter in this area immediately after the vermilion border. You go there and you put the filler, the first shot in this area. The second shot of the filler will be from the middle of the upper lip up to the tubercular area of the philtrum. There you go. You put a little bit more in the point, in the tubercular point, and then you move away slowly and you get the effect. Very easily you can make the profilometry of the upper lip. Now, as you see, the upper is quite good. The lower still has not been touched, so it looks very small. And you can imagine how it looks if you discompensate the proportion of the lower compared to the upper lip. What sometimes happen to some patients, even in final results. You should avoid always that. So let's go now to the lower lip. The same. I will do first the profilometry, enter in the middle part, and there you will see how the hyaluronic acid goes and covers the place. Very easily, you can have the effect, reducing the danger. There you see the injection. And on the other side, you will see exactly the same. There is a point. And you go and you leave your hyaluronic acid there. So now we have made the lips filling, but we are still watching what happens. Here we make a correction, as you can see. Layer 2, be careful there, because you are going to the lip border, to the wet lip area. So be careful and be very prudent in this area when you inject. Again, take a look at the mentalis muscle, because it's something that I will show you how to treat it with botulinum toxin pretty soon. Again, watching the lip, corrections, my recommendation, do all the job, and then keep a little bit of hyaluronic acid to make the corrections. There you can see, in a very nice way, you can have the effect. If you go to the lip corner, this point should be taken into account, and be very careful, because this point is, as I said, in the anatomical part, is in relationship with the facial artery, which goes usually 0.5 to 1 centimeter away from the modiolus. So if you go too far away, let's say, with this needle, you could hit the artery. So be very careful about this area. And if you see in the representation, there you can see how you should be very careful, taking into account the risks that lead 0.5 to 1 centimeter away from the body. We go now to the superior. This is something that can be discussed. Some people say that you shouldn't inject this area because of the weight of the hyaluronic acid. But if you are with a very light one, just doing profillometry, this is quite good. Take a look, the difference one side compared to the other, and you get how we change the orientation of the lip corner, which in one area goes down and the other area is more horizontal. So it's quite relevant in the beautification of the lip corner. Be careful and do that kind of approach, very conservative and very safe. Here, what we have done is just a profillometry of the upper part of the lip. Here you can see it has done a little bit to improve, but we make the patient do the movement of touching with the lower lip, the tip of the nose. When she tries to do that, she improves, she contracts very strongly the mentalis, she contracts a little bit the triangular muscle and the depressor labii inferiori. Here I mark the muscles, and then I will choose 2 points to block with botulinum toxin, 2.5 units of Botox, for example, to reduce the tension of the mentalis muscle. Here we go with the botulinum toxin, very vertical, very deep, 2.5 units per point. It's enough, will be enough to reduce the mobility of this muscle. So finally, we have done profillometry to improve the upper lip and a little bit the lower lip. We have done botulinum toxin to improve the chin area. So our final evaluation, you can see the patient there after the treatment, fuller lips, more mark the central area, the peripheral area, the lower lip also. She keeps the movement. She will reduce the contractility of the mentalis, but there you can see a very nice effect. Also in a lateral way, the difference between the upper and the lower is not so pronounced. So we can say we got a nice, interesting result with this woman in this profillometry and botulinum toxin treatment.
Okay, very well. I hope you like it. And after that, it was just an overview, just general. You can do so many things with the lips that I only in 25 minutes can show you a little bit of the technique and the art we have you know, all the many things that we have to approach the lip, but a good diagnosis is quite relevant. So now let's move to another area, to another very relevant area, that is the tear throw area. So I will show you an animated video with questions that we have prepared for the BUS Institute, and it's very interesting to see this little exercise, another 20 minutes, but try to follow it to understand what is happening in that very sensitive area and how to manage it. So let's go to the video.
Hi, this is the training on teardrop. You will take part in a unique immersive experience. We will study in detail how to apply hyaluronic acid in this complex and important area. Let's start.
The product with which we are going to work is hyaluronic acid. What type of G' will you use? Option A, high G'. Option B, low intermediate G'.
This hyaluronic acid is not recommended to fill in tear troughs, since the skin is very thin in that area. It can provoke what it's called a Tyndall effect, or generate an uneven surface with more or less filler quantity in different zones. Besides, with this kind of products, the edema can be more visible, more noticeable, and the result won't be the desired one in aesthetic terms. You have chosen the right hyaluronic acid. Low G' hyaluronic acids spread easily in the area and merge with the tissue. Though at the beginning an edema can be provoked and last a few days, this acid is the most useful to replace the fat in central and lateral soothe in the teardrop area. There are two ways of going in this anatomic area, with needles or with cannulas. Many doctors prefer needles to fill in the area, and some others cannulas. A cannula is a sort of blunt, flexible needle. Its thickness can vary, and a specific technique is required when using it. When choosing needles, they need to be thin, no wider than 29, 30, or 31 grams. You have to decide which method is better to fill in the tear trough area.
What type of technique is the most suitable and least risky for this procedure? Option A, needle. Option B, cannula.
If you use a needle to go into the soothe cavity, and you do it following an oblique direction, as you do with cannulas, there is a risk of hitting the angular artery, or worse, of injecting hyaluronic into the artery, provoking a distal embolization, and this has serious consequences. Even if the needle goes in vertically, there is still a risk of hitting a vessel when the needle gets closer to the tear throw angle. On the other hand, the infraorbitary artery is also vulnerable to injuries caused by piercing objects, such as needles. So there is no doubt the element recommended for tear trough procedures is the cannula. Using cannulas has lots of advantages. First, it largely reduces the risk of hitting a vessel. According to the type you choose, there are no chances that accident may happen. Secondly, the product spreads much more evenly, following the anatomic areas. Thirdly, when using cannulas, it is simpler to recognize the area in which the filler is injected and to determine the position between the ligaments, so as to optimize the results of the product. In short, we suggest using cannulas to work in the tear trough area. In aesthetic procedures, cannulas are blunt and flexible. Their thickness may vary, and they are classified with a number scale going from 16 to 30. The larger the number, the thinner the cannula is. The smaller the number, the thicker and more rigid.
What type of cannula is the most suitable to apply the product? Option A, 22G. Option B, 25G. Option C, 27G. Option D, 29G.
A 22G cannula is too thick for this area. The procedure will be painful, the product will be unevenly spread, and there can be a risk of hematomas. We don't suggest using it. A 27 grams cannula can be used, but the risk of vessel damage is higher. We suggest only very experienced professionals choose it, and with very subtle and thin hyaluronic acids, just to make some improvements or for very basic procedures in the area. A 29G cannula almost acts as a needle. The risk of provoking hematomas or hitting an artery is much higher. 29G cannulas, or others thinner still, shouldn't be used in this area or in other surface area. A 25 grams cannula is the best for this procedure. It has the right thickness, it is flexible, and there are no risks of vessel damage. You are right to have chosen a 25G cannula. Subpalpebral bags are more visible in older patients, since their orbital malar ligament has sagged. In younger patients, the orbital malar ligament is better toned, but they may suffer from an early fat loss in the central and lateral SUF. SUF stands for suborbital oculi fat. The central SUF is the first to be lost, and then the inner area of the central SUF. This provokes the groove known as teardrop.
What age group will most probably have this type of procedure done? Option A, under 50. Option B, over 50.
Patients over 60 are not the best candidates for teardrop filling. They tend to suffer from edemas and have adverse side effects. We suggest choosing another procedure with these patients. You are right. Younger patients are the best candidates for teardrop filling. In general terms, most of the teardrop filling procedures are carried out in patients under 60 and even under 40 due to the early loss of fat in their subocular area. There are two techniques for injecting teardrops using cannulas. You can go in obliquely from the lateral area and straight to the SUF. This way is easy to fill in the area. It is more difficult to go in vertically. This second technique is suggested in cases of serious fat loss in the inner midface connected to the teardrop. This technique allows the possibility to pull the orbital malar ligament upwards and build vertical columns to modify its position, even by perforating it.
What entry technique do you prefer using to treat the patient?
Elegiste la entrada oblicua.
Anesthetic cream application. We suggest applying cream on the working area 20 or 30 minutes before the procedure. There are different options in the market according to their concentration of lidocaine, prilocaine, or tetracaine. Teardrop area marking for oblique entry. The first mark is related to the impact that the orbital ring has on the working area. The second mark draws the lower border. It follows the zygomatic ligament, the lower part of the teardrop depression. In between these marks, the central and lateral SUF areas. The anatomic points that should be avoided are marked in red. The infraorbitary artery that comes from the infraorbitary foramen at the pupil's level, and the terminal branch of the face angular artery that runs along the nose side. There is also a little lateral zygomatic artery near the entry point. Entry point marking. Leave a 2-finger gap below the eye outer canthus, and at the same level, mark the entry point for an oblique entrance. This point will usually be under the zygomatic or on the zygomatic ligament, and you can reach the SUF area in the teardrop from there.
What volume of hyaluronic acid is the most suitable for this procedure? Option A, more than 0.5 cc per valley. Option B, no more than 0.5 cc per valley.
You shouldn't inject over 0.5 millimeters of any hyaluronic acid in teardrops. It would be too much and the effect won't be nice. If the product quantity is excessive, as you can see here in this virtual room, the upper zone will suffer the consequences. The ceiling of this virtual area, made up by the skin and the orbicular muscle, will adopt a curved form with an exaggerated convexity where there used to be a concavity. The right dose for teardrops is less than 0.0 millimeters each one. The immediate effect is nice, but bear in mind that the definite result of injecting hyaluronic acid in this area will be seen in 7 or 10 days after the application. Once the acid is stable and the edema caused by the procedure or by the product's capacity to absorb water has vanished, then the right answer is less than 0.5 millimeters in each teardrop, and eventually between 2.5 and 3.5 millimeters can be enough to fill in that area. First, cleanse the area with alcohol and then open an entry point with a needle 1 or 2 grams thicker than the cannula. For example, a 23 grams needle for a 25 grams cannula. As you can see in the picture, the needle goes through the epidermis and the dermis and reaches the subcutaneous cellular tissue. From that point, the cannula will perforate the zygomatic ligament and go into the SUF area.
What is the most suitable layer for this procedure? Option A, supraperiosteal. Option B, supraintermuscular.
In this area, it is very difficult to inject in the second layer, and it isn't advisable either. On the one hand, because the second layer is extremely narrow, and on the other, because the hyaluronic acid, when injected above the muscle, doesn't look nice. It looks uneven and won't improve the area, provoking more problems than benefits, including the Tyndall effect, when the hyaluronic acid is injected too superficially and results extremely visible. That is why we don't suggest injecting in the second layer in the teardrop area. This option is right. The cannula must go in deeply to the supraperiosteal layer. This is the fourth layer, almost touching the fifth, a bone layer that allows the filler to spread beneath the muscle, avoiding the Tyndall effect and resulting in hyaluronic acid's more homogeneous action.
What is the correct positioning of the cannula for this procedure? Option A, very high. Option B, medium or low.
Inserting the cannula at a medium or low level can be useful only when the volume loss in the central SUF is serious. If the cannula is too low, the hyaluronic acid can provoke an overlifting effect in the lower area, resulting in a depression in their upper area and the surging of palpebral bags. So inserting the cannula at a medium level could be sensible only when the volume loss is serious. We don't recommend inserting it at a low level, except there is a severe volume loss in the mid-face area. And in this case, we suggest going in vertically. It is recommended to insert the cannula at a high level when injecting hyaluronic acid, since it can improve the sagging inclination of the orbitomalar ligament provoked by the fat loss in the SUF. It is a practical and efficient way to improve the area and refresh the eye's expression. When injecting the filler, beware not to exceed 0.5 ml for each teardrop. Since the product has low G' and can be easily spread, press on the filling area to get an even effect. Press and spread. This way, you will have a nicer effect, aesthetically speaking, than if the product spreads naturally. That must be done manually. This is the second step after the application, and it's crucial. Going in with a cannula implies following exactly the same direction of the needle when it penetrated the dermis. This is crucial if you want to be successful when using cannulas. You must follow the same direction the needle did. When going in with cannulas, subtlety is of the essence. Go in through the opening you have created, past the zygomatic ligament, and reach the soothe. From there, you move towards the angle formed by both ligaments, while injecting small doses of hyaluronic acid. You must always inject when withdrawing, slightly moving to and fro, so the acid can spread evenly. As you can see, the lower part of the orbital ring should be reached and lifted. Then you should turn the cannula slightly to fill in the infraorbital fossa area. You are now in a virtual cavity that resembles a room. The upper wall is the orbital ring or orbitary ligament. The lower wall is the zygomatic ligament. The floor is the fat on the fourth layer, the lateral and the central soothe. The distal wall, which has a vascular component, is the angular artery, and near the lower wall, there is the infraorbitary artery, another vascular component with a treeform. The goal is injecting hyaluronic acid while withdrawing, especially in the orbitary ligament area, so as to correct the inclination towards the other wall and make it form a right angle with the insertion. Finally, turn the cannula slightly and move towards the orbitomalar fossa to give a nice aesthetic touch to the area.
You have chosen the vertical entry.
Okay, I will go a little bit faster to the vertical, because the vertical is something that usually is a little bit more complex and clear. I prefer the obliqual way. I would say 95% of the patients I treat it with the obliqual approach, and if I need to complement with a higher G prime for the deep medial fat pad, I prefer there, yes, to go with needles in a vertical approach. But anyway, I will show you just something related to the vertical, but it is not a way that I recommend, especially to begin to inject the tear through. The way to begin to inject the tear through is what you have seen up to now.
Resulting in hyaluronic acid's more homogeneous action.
What is the correct positioning of the cannula for this procedure? Option A, very high. Option B, medium or low.
If the cannula is pushed along at a superficial level all the way through, it won't reach the soothe properly. So this isn't the right choice. This is the right path to follow when the cannula goes in vertically. It goes into the second layer and immediately goes through the SMAS to reach the fourth layer. It first fills in the deep mid-face fat panicle, and then it goes through the zygomatic ligament to the soothe area. The cannula's upper limit is marked by the orbitary ligament. This ligament may sometimes end up being slightly perforated, or the hyaluronic acid may remain under it. As you first go in with the cannula, you find the ligament's opposition, indicating you are going deep. Go through the SMAS in the second layer. Then, reach the mid-face deep fat, which you are working to improve. Continue upwards. Go through the zygomatic to the ocular angle, limited by the orbitary ligament. This is a low efficacy technique that impacts in the mid-cheek. And in our opinion, it is not so effective as the oblique technique in the orbital ring area. We suggest going up to the orbitary ligament and pushing it mildly. You can microperforate it even, without reaching the intraocular area, so as to generate, vertically, columns to improve the tear trough. When going in vertically with a cannula.
Okay, there you can see what happened. The first ligament you have to cross is the zygomatic ligament. Then you enter in that room that I show. But after that, if you want to perforate the orbitary ligament, you have to be very careful because you are depositing hyaluronic acid in the intraocular area, which is quite something that can be discussed. Here you see, if you perforate this is easier, and okay, it's not a bad way, but if you go there, it's a little bit more dangerous, and I do not recommend that for people that is beginning to inject. So finally, this is something that could be done, especially if you have this ligament and this area a little bit lost in volume. There you see, if you want to feel the deep medial fat pad at the same time, okay, it could be a good approach. This is the deep medial fat pad. This is something that has sense, but you should choose for that a higher HA, a higher hyaluronic acid. So after that, as a conclusion, then move with your fingers always. It's quite relevant, and finally you will get a very nice effect that will be better with the days. Will be better in 3 days, 4 days. Always tell the patient that it's not the way that he looks immediately after the consultation, but it will improve a lot in the next 72 hours because it will be absorbing water, and this water will expand a little bit the volume. So this is the idea when you are choosing especially this way of approach. When you are treating tear throat, when you are treating lips, and whatever you are doing, okay, the way is to let the people have the time enough to get the results. With that, I think we have shown a little bit an idea, an overview, just an overview. This is a very extended task, a very extended area to give a lot of courses about it. That's what we are playing with Sonia, and I let her close the video session and open for some questions in case there are some questions.
First, can you see my screen?
Yes.
I'll do like just to play a quick video. It sounds to me that's so important from this amazing presentation you just given, that yes, we do have to look more into anatomy. Before we go to questions, I'd like to present a very quick video. Please stay with us. Okay, I would like to that American Academy of Orofacial Harmony and Boston Institute are joining for a course taking place in April in São Paulo, Brazil, and in Dallas in May. But what I would like to say is that for those people who are watching today, we are having giving a promo code that will give them 5% discount on their course. But I would like to ask Sergio, how do you ensure those professionals who are just entering the market of oral-facial harmonization injectables are doing it safely? Because as you pointed out, it was like so clear to everybody that anatomy and a very deep understanding of anatomy is so fundamental.
Well, I always tell the people that getting into injectables is like jumping into water. So you can read a lot, you can read papers, books, whatever, but the sensation you have once you jump into is absolutely different. There you begin with your learning curve. And we develop a way to make it safer working with the simulators. I have shown in the first presentation a very realistic, hyper-realistic simulators where you can practice all the times that you want. So in our courses, we will have the simulators so that the people can practice, can see the anatomy, can refresh the anatomical concepts, and can practice. The simulator has some of the things that you can resemble some of the effects. For example, in the lip, in the chin, in the cheekbone. So we want the people to practice, to do it. It's not only an issue to see, to watch the master injection, but to do it yourself. I always say, you can go to the cinema to watch Al Pacino or Robert De Niro, but now you are the actor. You have to act. The power is in your hands. So we work a lot, and what we are planning for our courses, we'll have a lot of it, of empowerment of the doctors to jump into the injectables field with a safe approach, practicing in simulators, and then going into human when they feel they are with the power, with empowerment to go into human and treat them.
Thank you. Yes, and in this course, we're also going to be covering the visual image aspect of planning the recomposition of the face and angles. Do you want to talk a bit more about that?
This is very important, because if you don't know where to fly, you can be an expert pilot, but you will not arrive anywhere. So your lecture about what is beauty and how to look the beauty in a face makes the map. And then once you have the diagnosis, it's like in medicine with the diseases. If you don't know what you are treating, you will never get success. Same in aesthetics. If you don't know the right approach and you, in a way, negotiate with the patient, which is best for her and what she likes, as you show very well in your lecture, many times they do not match, but many times yes, and you can slowly push the patient to the place you feel will be better for her. This is for her or for him. This is the way the aesthetic doctors we're beginning to think to improve the attractiveness capital of the patient. This is our endpoint. Finally, that the patient leaves the office or some days after more attractive than when he can. This is our endpoint. We have very clear it, and we have to diagnose, to make a plan, and to have the technical skill to do it right. This is finally how it ends. And we will like to teach in our courses we know that many people from many parts of the world is hearing us, people from USA, people from Brazil, also people from Argentina. We want to teach them with this approach and the technical skill to be successful in the injectables.
Right. So it's a bit of an artistry, like I was pointing out, right?
Absolutely.
It's not just injecting and making everybody to look the same with the model of maybe Western beauty or whatever, one country or another, because we all have different types of beauties. And Rose, that's fantastic. Is there anything else we'd like to add before we go? It's been an extensive lecture, and I'm sure people are very excited about all what they heard and probably want to know more. We put our email there. We're very happy to answer any questions later. But just before I say, before you say, we put the email there, and anybody who wants to pre-register for the book, for the courses, just to keep that promo code active. It's good to, if they enter in contact with us this year.
Absolutely, absolutely. Also, I recommend our page, although it is in Spanish, the Instagram BEESORG, because there from time to time we show different approaches and different things, and also it's interesting. But go to the course and follow us, because you will not regret, because we will teach you how to jump into the injectables area. This is a little bit the idea that Sonia and me, we have in mind.
And feel confident in doing so, because a lot of the courses out there, people watch a lot more than they do it, or they just do it in a few patients, and it's not enough. Like you said, you will go through right away from simulator all the way to patient in a very structured way, that when they come out of it, they say, oh, I know exactly what I'm doing. They know their anatomy, they felt the whole structure and everything, right?
Sometimes, Sonia, sometimes when I do master classes, I have some doctors that I know from other master classes, and I ask them, why are you doing again the watching process? The watching process is okay, it's fine. You can watch the best one in the world, okay. But the real thing is to put the hands in. This is the way you learn, no doubt. So this is the focus of our courses.
Okay, so with that, thank you very much.
Thank you.
And thank you everybody for watching. With that, we finish our session today. And remember, you can apply for the CE on the link to get your CE credits. Thank you.
Thank you.